Great, thank you guys. Thank you for inviting me. It's been a great course so far. My disclosures have not changed. So we know that patients that have tears that heal, they do better than those that you repair and they do not heal. But persistent tear rates remain after rotator cuff repair anywhere from 10 to 94% if you read the literature on it. So the real goal here is how do we achieve tendon healing? And we do know that there are risk factors for rotator cuff repair failures, and Joe Aboud, our course chairman, has been instrumental in terms of delineating a number of these, Bob Tashin as well. But the two that I think come up most commonly in my practice are the revision surgery, so the failed rotator cuff repairs, as well as massive tears involving more than two tendons. And those are the ones that I'm particularly interested in doing some biologic augmentation and to help edge it into my favor. So rotator cuff augmentation by way of a patch has been around for a while. There are two different philosophies or theories in terms of why it may work, the biomechanical as well as the biologic. The biomechanical rationale for graft augmentation is that you can offload the stress on the repair. If nothing else, if you can increase the overall surface area that the force is distributed across, then you can decrease the stress at the repair site. And there may be some mechanical benefits to doing that. There's also the biologic rationale that there's just quote unquote not enough tendon to repair. And by bringing in some more tendon, you can increase the biology and maybe serve as a scaffold for cell recruitment or other biologic therapies. There's been good data out there in terms of using dermal grafts. This is allografts. Here you can see this is massive tears, allograft versus no patch augmentation. MRI had 85% healed in the augmented group versus 40% in the non-augmented group. And here's another study that showed an extracellular matrix reduced the incidence of re-tear and improved patient outcomes, and it was a viable option. But the problem with using a patch typically is that it's time consuming. You have to do your rotator cuff repair, you have to put graft suture placement, you have to size the graft on the back table. Suture management can be a disaster. You have to put the graft into the shoulder. This is difficult even for experienced surgeons, and it interrupts the normal surgical workflow, longer surgical anesthesia times, and it's expensive because you open up a lot of this patch, you pay for the whole patch, use a very small portion of the patch. So this has been a barrier, I think, to a lot of us. I think a lot of us philosophically like the idea of using a patch, but I think when it comes to technically applying it, that's been a barrier. But there are new technologies on the market now. This is one. This is a bovine patch. You can see here, as Bill showed us, this is a U-shaped tear, so understanding the personality of the tear is very important. So for this one, I'm not going to be able to mobilize this from medial to lateral, so I'm going to mobilize it from anterior to posterior. So I do a margin convergence repair on this. But obviously that tissue is of poor quality, and I'm going to want to augment that. So I'm going to put this patch in. It has a neat delivery system. It opens up like an umbrella, places it. I make a portal there just anterior to the acromion. I take a peek to make sure that where I'm putting my little staples, I'm not disrupting my sutures, and I'm going to fix those with absorbable staples on the medial side. And then on the lateral side, we're going to put this patch down using some peak staples that go into the bone here. I think the real learning curve for me on this is just not to over-tension this. I think a lot of us want to see this as a biomechanical device. It's really not. It's just a biologic augmentation device. And so you don't want to over-tension it because you will tear the graft if you try to pull on it laterally there. So here's if you go to the next slide, so this is a revision rotator cuff repair. You see in this patient, it looks relatively benign. I've already done a biceps tenodesis there in the groove anteriorly. So for this though, given the fact it's a revision, I don't like my healing abilities on that, so I do a standard medial row repair. I use mattress sutures. I like to tie the medial row, but then I'm using, this is dermal allograft. These are freeze-dried pledgets. They have a central canal bored out of them through which a threader tab is placed, and that's how it comes out of the package. And all you do is after you've been able to pass your medial row, tie your medial row if you want, you can then pass these sort of make a graft thing over your stitches and then load it up into a lateral row. And so it's a pretty easy, convenient way to add some biologic augmentation. So depending on the tear pattern that I have, I'm either using that bovine patch, and I can just place that over, say, a margin convergence repair, or if I have more tear that's more amenable to a more traditional transosseous equivalent repair, then I'll add these dermal allografts on top of it. So I do think healing is important to maximize outcome, but unfortunately it does not always occur due to compromised biology. I think patch augmentation has been shown to be effective at increasing healing rates, but the problem with using it is that historically it's been very technically difficult. I think there's new technologies that are out there now that can decrease that barrier and allow us to provide this to our patients in a more effective and time efficient manner. So thank you very much.
Great job, Larry. All right, Melissa, we're going to start with you first. What's your score and what's your comment?
All right. It was great. I learned a lot. 10 out of 10. I was going to ask, do you soak those patches in any kind of like aspirate or anything like that prior to utilizing?
Yeah, that's a good question. You can't soak them before you do it, because if you do, it's going to fall apart, basically.
Okay.
But after you put it in, I think you can dry scope it, so you can take the fluid out, and then you can inject something if you want, PRP or BMAC or whatever it is. I'll be honest, I have not done that, but it's an interesting idea.
Jerry?
So I thought that was great, Larry. Very, very well organized, difficult topic, and good combination of background material, data to support it, and technique. So I give you a 10 out of 10. Give me some sense of what percentage of full thickness chronic 2 tendon tears you use a graft in.
So 2 tendon tears, I'll probably use it in 80% of the time for 2 tendon tears. So yeah, my main indication for doing it are massive tears, so greater than 2 tendon tears, or revisions. Those are the 2 most common.
Butch?
Yeah, Larry, that was really great, 10 out of 10. One question that's maybe more philosophical. You know, Dr. Ionati is sitting right there in the front, and he described when grafts were first started to be applied in an augmentation fashion that there's a delamination that occurs between the native tissue and the graft. You know, general surgeons have been using grafts and patches in abdominoplasties and herniorrhaphies for years, and they use it just to support the load on the tissue till it heals. Do you think that's really why you're using the graft or the patch, or do you think it actually augments the tissue biologically?
Yeah, I think so. The only way that it has, of those biologic augmentation patches that I showed, the only way that theoretically it can affect the biomechanics is by increasing the surface area. And if you increase the overall surface area by which the force is distributed, theoretically you can decrease the stress at your repair site. So I think that is a hand-waving philosophical type thing. I think it's more just to enhance the biology.
Sarah, what's the score and comment?
It was great. Your videos were perfect. Good technique. I'm curious, when you do those, do you do them on every revision, or do you assess the tissue first?
Yeah,
so you go into every revision planning to put a patch? Okay. And do you ever augment with stem cells at all? Have you any?
Yeah, I have not gone that far. I think there's intriguing data in terms of Gus Mazzacca, if he's still here, has some interesting data on using BMAC. So I think that BMAC is intriguing. But I'll be honest with you, I have not incorporated that into my practice.
Larry, I don't have a question at all.
Yeah, I just have a question regarding low-grade infection. In cases of recurrence, sometimes we don't understand anything, and sometimes, you know what, when we revise this patient with open surgery, and then we take some sample, and then we can find that there is a low-grade infection in the sutures and everything. So how do you manage? Are you looking for some samples every time you go, or do you feel that something has been infected, or are you systematically acting, and if you are afraid about that, do you still put a graft on it?
It's a great question. I mean, I think it comes back to how aggressive do you work that up? And I will be completely honest with you that in terms of, like, if you have a failed cuff repair and the MRI is not showing any overt signs of infection, I do not go out of my way to rule out an infection by way of an aspiration or blood work or so. That's different than an arthroplasty. All failed arthroplasties, I do send them through an infection workup. But yeah, I do agree with you. I think that this subtle P. acnes infection is probably a pretty good cause for a failed rotator cuff repair, especially in that 50-year-old laborer or so, male. But it's, what do you do, Laurent? Do you routinely work patients up?
I don't know what to do. This is why I'm asking.
Oh, well, yeah. Listen, if you haven't figured, that made me feel a lot better. I didn't have a great answer for you.
Every cuff which is failed, I do samples. All of them.
Yeah.
And I'm trying to find. And I was amazed to find much more than what I expected.
What percentage of those are positive?
I don't know.
Oh.
I don't know. I can't tell you. but I would say that it's around 30%. It's around. But I haven't made I think that would be an interesting study. Just to have the people, working on every revision of rotator cuff, just having a sample, and then building a prospective study saying, this is the amount of infection that we have found on that. That would be
Great
interesting.
idea. Brad.
LeBron, have you correlated that all with preoperative stiffness? So the failed cuff that's stiff versus the failed cuff that's not stiff and infected?
I'm totally on the same page as you. I think there's two reasons of stiffness post-op. The first one is pre-op stiffness, and the second one is only post-op stiffness with no pre-op inflammation. And I guess that on that cases, and even more when the patient has a lot of pain that you don't explain, and then you don't explain the pain, and then you see and you have a CT, and then amazingly it's not a big cuff, or it was a very big cuff where you spend 2 hours to operate on it, and then you have a low-grade infection.
Laurent, can I just ask one? Have you been able, I know it's probably early, but have you been able to correlate the 30% who are infected with anything specific in those patients? Grafts, more anchors, different PRP, anything else that's going into the shoulder?
No. Honestly, when I say 30%, it was like the question that you ask your fellow, how many times
Yeah.
you are doing. So it's around 30%. I'm just thinking that this would be an interesting study.
Yeah.
And I think that correlated with the pain, the stiffness, the infection, just trying to understand why do this small tear that sometimes we repair, we're very happy, and then we see the patient who is not doing so well, and then finally they have something, and then we revise them, and then make a sample, and then we find this acne. Thank you.
Larry, one more question about the bovine patch. I don't have personal experience with it, but I've heard it's very friable, it's difficult to work with, and also can cause an inflammatory response. What's been your experience with it?
Yeah, so it is friable. You really, I think, again, the technical pearl there is not to over tension it. Like you can't manipulate it really. So you just have to put it on and just like fix it where it lies. I have not seen the inflammatory response. I mean, I know with the porcine, small intestine submucosa, there's been problems with that. Knock on wood, have not seen it with this.
Great, thank you. All right.